Hello guys, welcome to this video about how to approach acute coronary syndromes in emergency settings. So in this video, I'm going to give you a simple definition. Then I'm going to explain to you how the patient with acute coronary syndrome is going to present to you and uh, what are you going to do this patient regarding diagnosis and treatment. So acute coronary syndrome is defined as decrease in blood supply to part of the heart, causing damage to the heart muscle. And mechanism of uh, this condition is mostly by the atherosclerosis, oftenly most of the times, and it is a gradual buildup of cholesterol and fibrous tissue and plaques in the walls of the coronary arteries. And these plaques become unstable at some point, and they're going to be a rupture and promote formation of blood clot that blocks the artery, and that leads to a myocardial infarction. The other mechanism is the metal angina, which is a spasm of the coronary arteries, and there is a rare type of mechanisms like anemia and hyperthyroidism and more. The cardiac enzymes are the gold standard for diagnosing myocardial infarction. And regarding anatomy, I want you to focus on the left anterior descending artery. This is a branch of the left main coronary artery, and also the left circumflex artery, which is the other branch of the left main coronary artery, and the right coronary artery. This drawing here shows the left main coronary artery, and it gives the left anterior descending artery and the left circumflex artery. And there is the other artery, which is the right coronary artery here. The right coronary artery supplies the inferior part of the heart and the posterior part, while the left coronary artery supplies the anterior part and the septum and also the lateral part. So acute coronary syndromes, there's three types, and there is a crescendo type of pattern. So there is an unstable angina, which is worsening of already existing angina, and there is a chest pain at rest or with the previously tolerated exertion, and cardiac enzymes are negative regarding unstable angina. And the unstable angina crescendo into either STEMI or non-STEMI. STEMI is the ST elevation myocardial infarction, which is a transmural infarct involves the permanent occlusion of left anterior descending artery or left circumflex or right coronary artery. The cardiac enzymes are positive regarding STEMI. The non-STEMI, which is non-ST elevation myocardial infarction, it is non-transmural infarct. It involves the transient or partial obstruction of coronary artery or small intramural vessel obstruction. Cardiac enzymes are also positive in non-STEMI, and I want you to focus on this point here. There is 1 in 3 patients that would not survive when it comes to acute coronary syndromes. So it is a very important uh, topic that you want to consider and you want to review very well. So patient presentation, there is a classic presentation and there is non-classic presentation. So the chest pain is the main symptom in the classic presentation. It is a tightness, squeezing, pressure, or crushing in character. And it is retrosternal and it is poorly localized. The anginal chest pain lasts from 2 to 10 minutes and brought on by exertion and relieved by rest. The unstable anginal pain lasts from 10 to 30 minutes and it is chest pain at rest, while the myocardial infarction pain lasts longer than 30 minutes. Lasts longer than 30 minutes. The chest wall, there's a chest wall tenderness, and there's radiation of the pain to the arms, neck, and jaw. There might be sweating, dyspnea, nausea, or vomiting associated with these symptoms. Regarding the non-classical presentation, uh, it occurs more frequently in females, racial minorities, diabetics, elderly, patients with altered mental status. And the chest pain lasting for seconds or constant pain lasting for 12 to 24 hours without change in intensity. And that's the regarding the chest pain. It's like different from the classic chest pain. And the dyspnea at rest or with exertion without chest pain. That's like sometimes you get chest pain lasting for seconds or constant pain, and sometimes there is no chest pain. There is only dyspnea at rest or with exertion, or there's just shoulder, arm, or jaw discomfort, and there might be only nausea or general weakness or diaphoresis. And this, the non-classic presentation, presents in 47% of the times. So it is very significant and it is often delayed in diagnosis. So you need to pay attention to this. And those are maybe the most common presentations. Maybe your patient is going to be presenting in a different way. Always take this possibility. One time, a wise person said that the map is not the territory. So everything you find in books or in seminars and lectures, it does not have to be the case in when you experiencing it in real life. Now I want you to watch out for this stuff. So do not exclude acute coronary syndromes if the ECG is normal, examination is normal, or patient is less than 30 years old. Epigastric or upper abdominal discomfort, even when relieved with antacids, raises suspicion for acute coronary syndromes, especially for the patient more than 50 years old or those with known coronary artery disease. So antacids that relieve epigastric pain does not exclude acute coronary syndrome. It raises the suspicion for it. Now, for the diagnosis, you thinking ECG, cardiac enzymes, those are the most important. You can also do some blood tests. The electrolyte is important because there is a predisposition to arrhythmia if there is dearrangement in the electrolytes. So you want to make sure that your electrolytes are within normal range. And you can do complete blood count to identify secondary causes of non-ST elevation myocardial infarction. And you can do liver function tests and blood urea nitrogen and creatinine to make sure that the kidneys and liver working well. So, uh, when the drugs that you give the patient that are renally or renally executed or by liver metabolized, those wouldn't toxify your patient. So now I'm going to explain the ECG more. So for the ST elevation myocardial infarction, the ECG uh, is uh, classified as the three different time frames: the hyperacute changes, the acute changes, and the chronic changes. So before I start by talking about this, I want you, uh, if you don't understand any of the stuff that I'm going to talk about, you want to go back and review your ECG basics. This is very important. The ECG is a very cheap and fast tool, and it gives you a lot of information. So you want to make sure that you have a very good understanding to your ECG. So in the hyperacute changes, in the first few hours after the myocardial infarction, and they include tall widened T waves, and there is upward sloping ST segment. The ST segment lose normal upward concavity, then straightens and slopes upward before becoming elevated. Well, it becomes elevated in the acute phase. So there is increase in the ventricular activation time, which is the interval between the start of the QRS and the apex of the R wave, more than 0.045 second, because the infarcting myocardium is a slower to conduct electrical impulses. And there is increase in the height of R waves in inferior leads in inferior MI. Those are really hard to notice, but the first two are easier. Regarding the acute changes, those start few hours after the myocardial infarction and continue for hours or days, and they include the ST elevation, which is significant if elevated more than one small square, which is 1 millimeter, in two limb bleeds, or more than 2 millimeter, which is two small squares in two adjacent chest leads, two small squares in the ECG paper. This is the most important ECG change, the ST elevation, and the the naming, the STEMI and the non-STEMI is according to this to the ST elevation. So there's reciprocal ST depression may occur on the opposite leads, and the pathological Q waves, they reflect electrically inert necrotic myocardium, and there might be conduction problems like left bundle branch block and right bundle branch block. The chronic changes are permanent changes that start a few weeks after the myocardial infarction, and Q waves remain, and everything else goes back to normal. So the chronic changes only involve the Q waves, and which remain for the rest of the person's life. So now for the ST elevation myocardial infarction localization. So there is uh, different locations to the myocardial infarction, and those can be identified by the ECG. The inferior in the leads 2, 3, and AVF, and it involves right coronary artery in 80% of cases and left circumflex in 18% of cases. The anterior is in the V2 to V4 leads, and it involves the left anterior descending coronary artery. The anteroseptal in the leads V1 to V4, and it also in the left anterior descending artery, and the lateral is in the leads 1, AVL, V5, and V6, and it is in the left circumflex artery, and posterior myocardial infarction is ST depression in V1 and V2, and ST elevation in V7 and V8. Those are the posterior leads. And it is in the right coronary artery. The blockage is in the right coronary artery, At the anterior, there is a left bundle branch block, ACG changes, and it involves the left anterior descending artery. So for the non-STEMI ECG changes, it could be normal, and the ECG could be normal, I mean, and sometimes there's horizontal or down-sloping ST depression, more than half small square, and there's symmetrically inverted T waves, more than two small squares. And if there is diffuse precordial ST depression more pronounced in leads V4 and to V6, this may indicate a stenosis in the mid left anterior descending artery, and if change is evident in leads V2 to V3, it is more suggestive of stenosis of the left circumflex artery. And diffuse ST depression, including both precordial and extremity leads, associated with ST elevation more or equal to one small square and leads AVR and lead AVR may indicate a stenosis in the left main coronary artery or proximal occlusion in the left anterior descending artery. So that's it for the ECG. Now for the cardiac enzymes, like I said, those are the gold standard in diagnosing STEMI and non-STEMI. And they are elevated in STEMI and non-STEMI, both, and they are normal in the unstable angina. The troponin I is the main cardiac enzyme. It began to elevate approximately 6 hours after the onset of chest pain and remains elevated for 1 week. And the CKMB, which is specific for cardiac muscle, begins to elevate 6 hours after the onset of chest pain and peaks within 24 hours and normalize in 72 hours post myocardial infarction. So now for the treatment of the ST elevation myocardial infarction, the first thing you're thinking about is the percutaneous intervention. Angioplasty with stenting is the treatment of choice for the ST elevation myocardial infarction. But if the PCI cannot be performed within 90 minutes of diagnosis, then thrombolytic therapy is an alternative. Benefits reduce with time. Thrombolytic therapy risk exceed benefits after 12 hours of diagnosis. So it is not recommended after 12 hours. So thrombolytic therapy, there's different types. There's the TPA, and there's the streptokinase, and there's absolute contraindications for the thrombolytic therapy, which is hemorrhagic strokes, non-hemorrhagic strokes within 3 months, active internal bleeding, aortic dissection, head and facial trauma in the last 3 months. The relative contraindications are history of severe hypertension, blood pressure of 180 over 110, major surgery or trauma within 1 month, allergy to streptokinase, active peptic ulcer disease, and current use of anticoagulation. So you want to make sure that your absolute contraindications are not present in your patient if you want to give them the thrombolytic therapy. There's another treatment that you want to give your patient. So in general, you want to decrease the myocardial oxygen demand and you want to increase myocardial oxygen supply. That's like your major plan. You're thinking beta blockers, they slow the heart rate and they decrease myocardial oxygen demand. And they decrease mortality associated with myocardial infarctions. So they are very important that you give them to your patient. And you're thinking atenolol, 5 milligrams slowly intravenous over 5 minutes, and you repeat it once after 15 minutes. And the other option is the metoprolol, which is initial dose of 5 milligrams IV every 2 minutes as tolerated for 3 doses. Then if the patient tolerated the first 3 doses, then give 50 milligrams orally every 6 hours, starting 15 minutes after the last IV dose. And if the patient is intolerant of full IV dose, you stop giving IV doses and you give your patient 25 to 50 milligrams according to their clinical condition and how much they tolerate. And this is contraindicated in uncontrolled heart failure, hypotension, bradyarrhythmias, and COPD. So you want to make sure that your patient pulse is good for the beta blockers, and you want to make sure that your patient is not uncompensated heart failure because it's gonna make your its heart failure worse. You thinking nitrate? Those are pain relief and decrease after load, so they decrease myocardial oxygen demand. And you give 3 doses of sublingual nitrate, 0.4 milligrams every 5 minutes. If no pain relief, then you're thinking intravenous nitroglycerin. And those should be titrated upwards until symptoms are relieved. And in hypertensive patients, until blood pressure normalizes. Careful blood pressure monitoring while giving nitrates because uh, nitrates decrease blood pressure and your patient might go into hypotension. When side effects like hypotension and headaches occur, nitrates should be stopped. And nitrates is not contraindicated if patient took phosphodiesterase type 5 inhibitor within 24 hours. It causes severe hypotension if you give your patient nitrate with this drug. You thinking morphine? This is a pain relief and decrease afterload, so it decreases myocardial oxygen demand. And it's mainly for pain relief. So you're thinking doses of 2 to 8 milligrams repeated at intervals of 5 to 15 minutes until pain relieved or side effects occur. The other thing is to increase myocardial oxygen supply, and this is achieved by oxygen and only in patients who are hypoxemic, arterial oxygen saturation is less than 90%, or who have respiratory distress. Aspirin make blood thinner, so it make the blood reach more into the heart muscle, so a decreased mortality associated with myocardial infarction. So you have now two drugs that decrease mortality: the beta blockers and the aspirin. Those are most important that you give to your patient. And you're going to give 160 to 325 milligrams per oral aspirin within minutes of presentation. If patient can't take oral medications, then give 300 to 600 milligrams per rectum. Then continue with maintenance dose of 81 to 325 milligrams every day. Aspirin is very interesting drug. It works as antiplatelet as in this dose range, and it works as analgesic and anti-inflammatory at different dose range than this. And I have a video I explain aspirin in a very good way. You can check it out if you want. Link in the description. Finally, IV heparin prevent further thrombus formation. Thank you guys for watching. Please like this video. This series I have more videos in this series coming, and it's going to be very good. So stick with me, subscribe, like this video, and watch the rest of the videos in this series. Thank you very much.